I will present a case of lymphatic malformation of the head and neck. Our patient is 3 years old male with swelling at the right side of the head and neck with protruding tongue and inability to close his mouth. This swelling was found since birth and growing in proportionate to the patient growth. The patient has facial disfigurement, excessive drawing of saliva, and inability to close his mouth, but with no previous attacks of suffocation or airway affection. Usually we use the series classification of lymphatic malformation of the head and neck. It is a classification which classifies lymphatic malformation of the head and neck according whether it is unilateral or bilateral, and its location or extension suprahyoid or infrahyoid. Type 1 is unilateral infrahyoid, type 2 is unilateral suprahyoid, type 3 is unilateral infra and supra, type 4 it is bilateral infra, and type 5 is bilateral infra and suprahyoid. And this is a photo of our patient at its initial visit for vascular anomaly clinic. Usually the importance of clinical presentation and physical examination of vascular anomalies, as it frequently helps us to reach the correct diagnosis. We also use Doppler ultrasound and MRI to know to detect to reach the diagnosis when it is uncertain and to know the extension of the lesion. We usually start by ultrasound Doppler due to its wide availability and low cost and lack of ionizing radiation. But also it has some disadvantages as it is operator dependent and it is restricted penetration and limited field of view. MRI nowadays is the most important tool as it helps us to know the diagnosis and to know classification, to know the extent of the lesion and its relation to the surrounding structures. MRI protocol for vascular anomalies include T1 weighted images for basic anatomical assessment and the T2 weighted images for extent evaluation and to detect the presence of fluid component in the lesion. Contrast MRI angiography can evaluate the vascular characteristics of the lesion. Lymphatic malformation can be macrocystic or microcystic. In Doppler ultrasound, macrocystic appear as thin wall cyst with fine septations inside. This cyst doesn't show any venous or arterial waveform. Sometimes waveform appear in the fine septation. Microcystic, we cannot by Doppler ultrasound to discriminate each cyst separately, but they usually appear as regular hyperechoic lesion. In MRI, T1 weighted images, lymphatic malformation appear as lobulated septated mass with intermediate to decreased signal, but in T2 it appear increased signal intensity. In contrast enhancement, macrocystic doesn't show contrast enhancement except in the fine septations present in the lesion. Microcystic usually doesn't show any contrast enhancement. Returning to our patient, we did MRI vascular anomaly protocol. It shows lobulated multilocular cystic lesion at the right side of the face, measuring 8 by 7 by 8.5 with low signal internal septation with hemorrhagic fluid inside and multiple fluid levels seen inside. Its extension was huge. It extended from the infratemporal fossa superiorly to the supraclavicular region inferiorly, and from the masticator space laterally, causing bulging of the skin contour over the cheek to the right parapharyngeal space medially, displacing the laryngotracheal column to the contralateral side. It also involves the floor of the mouth and tongue base, displacing right genioglossus and mylohyoid to the contralateral side. Our first question, what is the next step in management? Either to conservative management or to do bleomycin injection or surgical intervention or to start sirolimus. Okay. Actually, we started sirolimus.
Yes, we can see, Muhammad, that most will try at first a non-surgical technique, whether surgical intervention only 4%. And of course, it's now treatment of many of the vascular anomalies are changing over the last years rapidly from being at first a surgical problem to minimal invasive techniques like injection or interventional radiology. And more recently, which is your thesis, about using the drugs in modifying the history, natural history of these malformations. Yes.
Okay, Dr. Amr. We actually started sirolimus. Sirolimus is a drug used at first for in renal after renal transplantation to prevent organ rejection. Sirolimus is mTOR pathway inhibitor. mTOR pathway is a pathway in the cells responsible for proliferation, growth, and angiogenesis and lymphogenesis. So using sirolimus in vascular anomalies to stop or used as an anti-angiogenesis and anti-lymphogenesis. Actually, we started by sirolimus, not by bleomycin injection, as the patient has shift of the airway to the contralateral side, huge lesions in the neck and in the floor of the mouth. After bleomycin injection, the patient could have attacks of infection, inflammation, which may increase the risk on the airway. So we started with sirolimus. Sirolimus was started on 2 milligram per meter square. We have to follow up the patient after start of sirolimus clinically to make sure that the patient has no attacks of respiratory tract infection or GIT infection. We follow up the patient laboratory by complete blood count, liver function, kidney function, and we do sirolimus trough level to detect the level of the drug in the blood. Usually the therapeutic level is between 5 to 15. In our patient, he developed attacks of diarrhea in which the dose was decreased to 1 milligram per meter square for 2 weeks. Then the dose returned to 2 milligram with no further attacks of diarrhea. Sirolimus trough level was done, and it was 8.5 nanogram per deciliter, which was within the therapeutic range. After start of sirolimus, clinically the patient, the protrusion of tongue decreased and the drawing of saliva also decreased. 5 months later, this is a photo of our patient. The swelling of the tongue decreased and the drawing of saliva actually decreased. We did MRI vascular anomaly protocol, which showed the regressive course of the lesion from 476 centimeter cubic to 352 centimeter cubic, which is a decrease of about 30% of the size of the lesion. Also, regression of the mass effect of the lesion posteriorly on the sternocleidomastoid muscle, carotid sheath, and also medially on the oropharynx with less displacement to the contralateral side. And this is the photo of the MRI before start of sirolimus and 5 months after start of sirolimus. It shows decrease in the size of the lesion and less displacement to the contralateral side. Our second question, what is the further management? Either to continue sirolimus or to bleomycin injection or to do surgical intervention or to stop sirolimus and continue and keep the patient on conservative management. Patient stopped sirolimus after 8 months from its start, and bleomycin injection was done for the large cystic lesion in the face.
No, we have to know the result of the ball, Dr. Muhammad, please.
Sorry, Dr. Osama, البول
The ball is not working or still in
doesn't appear on my screen.
Dr. Amr, Dr. Can you tell us about the ball results?
Okay, Dr. Osama. Okay, Dr. Osama. This is the result.
Good. So continuous sirolimus was about 60%. Then bleomycin and surgical interventions equal 20%. So yes, Dr. Muhammad.
We stopped sirolimus after 8 months from its start, and bleomycin injection was done for the large cystic lesion in the face. We repeated the MRI after 6 months from the previous one, and it showed decrease in size from 305 in the previous MRI to 150, which showed a decrease of about 50% of the volume of the lesion, and 70% from the initial MRI done 11 months before this MRI. Also regression of the internal large and small cystic lesions. This is a photo of the MRI before sirolimus and after 5 months of sirolimus, and after 11 months from the initial visit of the patient to our clinic. And this is the photo. The effect is obvious. Before, he cannot close his mouth with frequent drooling of saliva. After 5 months, decrease in size of the lesion and improvement. After 11 months, no drooling of saliva, and the patient could close his mouth, and reduction of the size of the tongue. Okay, thank you.
Thank you, dear Muhammad. We like some comments. I will look for the chat, and we can invite some of the participants who need to have any comments. We have one question about why you did not continue on sirolimus. And we have Muhammad, our dear Muhammad Sameh Shalabi raising his hand. I think I can unmute him.
Hello.
Hello.
Can you hear me?
Muhammad Zek.
Yes, very nice to see you.
We are very happy.
Hello, can you hear me? Yeah.
Yes, Muhammad, you are very happy. Also, we are very happy to be with us in this meeting.
Yes, the pleasure is all mine. A very good job with that lymphatic malformation. Can I ask, what protocol do you usually use for the sirolimus, and what is the overall what are the things that you worry about, and why would you stop it? Is there a certain complication that you're afraid of if you carry it on for a longer period of time?
Yes, Muhammad Ali, you want to ask to answer some of these questions?
Okay, thank you, Dr. Muhammad. We usually start by a dose of 2 milligram per meter square. In neonates, the dose is 0.8 milligram per meter square. We usually follow up the patient clinically, as some patient has attacks of respiratory infection or attacks of diarrhea due to GIT infection. Some patient has attacks of fever. And we follow up the patients clinically by complete blood picture, kidney function, renal function, kidney functions, liver functions, and sirolimus trough level. I think we stopped sirolimus in this case, as the MRI showed improvement of the mixed or the microcystic component of the lesion, and this was there were macrocystic lesions that can be injected.
Yes, I
Dr.
think.
Dr. Osama, if you would like also to
Yes.
comment.
Yes, I can comment. Please, Amr, if you have something, and I can comment on the management.
You can start, Osama, please.
Actually, we want to show in this case presentation that you have to make a trade-off all the options for treatment of these difficult conditions. And you have to consider the condition of the patient, you have to consider the extent and the type of the lesion, and you have as well to consider your setting and what are the setting situations in your centers for managing these cases. Actually, when we started to deal with this patient, as you see, in fact, in the MRI, it's very important to know, is it macrocystic or microcystic? Yes, this can be, this information we can have from the ultrasound, but in the MRI, you will know the extent as well of the lesions, where is the lesion extending. And in fact, here in these patients, we didn't show the inclusion of the chest is very important in cases of cystic hygroma too, because usually cystic hygroma of the neck can extend in the chest. And in fact, the presence of the cystic hygroma in the chest as well is very important to account for, because this as well will determine part and the way that of the treatment that you are dealing with. As you know, pleomycin injection or sclerosing injection in general is more beneficial and more successful with the macrocystic type, where the microcystic type injection is not a good option. In this patient, we have both mixed macrocystic and microcystics. So, and in fact, you have to know and to appreciate that sirolimus is a dangerous drug. Sirolimus is an immunosuppressant drug. It's not a drug without complication, and the complications can be so severe, as well as it's a very costly drug. If we consider the economic factors, especially in our situations, the drug is needs compliance. So we are fortunate that the family of these patients are very cooperative, because you have to continue the drug for a long time, and you have to control the therapeutic level of this drug by doing a trough assessment of the level of the drug. So all these factors should be considered. So when we saw that the sirolimus had done the major job of relieving the compression on the trachea, because I forget to tell you that when you do MRI or CT scan for neck or mediastinal masses, you have to assess the airway, the trachea, and there you have to assess the risk for tracheal compressions and the need for tracheostomy or endotracheal intubations if the mass had been flourished or inflammation occurred. So this is very important to consider assessment of the airway in these patients. So our strategy was, first we used the sirolimus for 5-6 months, reduce the volume of the lesions, which luckily had relieved the compression on the trachea. So this can give us a chance to go to the pleomycin, even if the pleomycin in the first increases the size of the lesion and do some airway compression. It will not be so risky for this patient. Although, of course, this patient should be injected in the hospital and followed up in the hospital at least overnight to observe for any deteriorations in his airway. So our second step was to attack the macrocystic lesions using the pleomycins, which had shown good results. And now what we are left in with these patients actually is the size of the tongue. Still the size of the tongue is not the normal one, but at least he can close his mouth, no more drooling. But it is the tongue size as well, so it is improved, but we are still in need to address. And number two as well, sometimes with these patients, there is a problem with their growth of the mandible because of some involvement of these lymphatic malformations to the mandibular structures. Fortunately, this patient had no such things. So in some patients with cystic hygroma in the neck, you will find that their mandible is oversized and increase in size with time, and they maybe need to be addressed by the maxillofacial interventions. So maybe this answered the questions about the mixing and the use of the different options at different times, and why we choose the sirolimus first, then we add the bleomycin. Surgery in these cases, please, because I want a very clear message. Surgery in the series 5, like these patients, is not the first choice for management, even in the neonates. So results are not good. You will not be able to cure the patients by your surgery, and complications are very high. And we have now a drug or a strategy that can help us safely to manage these patients, which is the sirolimus. And we have to make use of this important drug for managing these difficult cases. Thank you.
Thank you, Dr. Osama. By this, we have came to the end of our meeting. We have tried to make the time restricted to about 1 hour. And before we end, we are very happy to inform the participants before we end this meeting. For anyone who needs to any comments on these cases?
Any comments about any of the cases, about the paper? Because we send the paper for all to read so they can participate actively. We need everybody to talk.
I may ask Mohammed Sameh a question about this collaborative work between centers, because yesterday we have watched Dr. Sameh Shehata lecture on the RedCap application for centers sharing patients together. Mohammed Sameh, I would like to, if you are still there, I would like to hear your comments on this type of studies. Are you here, Mohammed?
Yeah, I enjoyed it very much. I think it's very good because otherwise you will not get enough data per any center to be able to withdraw, to have appropriate conclusion. So I think it's certainly a good way of trying and gather information.
But as you can see in this paper, Mohammed, they made a national but not international, because I think cooperation between different centers, it's not just collecting data. I have several queries, but I couldn't ask Dr. Sameh Shehata because it's not just to make a study, that not just collecting data. How you organize the work, who will write the paper, who will be included in a paper with so many
So I think
moreover, the arrangement, who will be the first author, who is the second author, who is the last author. Very difficult.
Usually,
I think
yes,
it may be better here national to have a national.
I think what usually happens with these sort of studies is in the original design of the study, there need to be an agreement of what parameters will be used. So there are two examples that we had in the UK. One was looking into spinal anesthesia for hernias, and it was multicentric, and it was across the whole country, and it was agreed that the best way to get the authors would be, for example, whoever will contribute the most number of patients. Another study was collaborated regarding right iliac fossa pain and appendix, and in the study design, it was made clear that the group of people who will be responsible for the writing and the drafting, will be X group of people. So I think it all need to be in the study design, and depends on what the question that the study is trying to answer, depending on who will be responsible for it. If the question is a clinical question, then sometimes people use the centers with the largest number of patients. If the question is a statistical or a demographic question, then sometimes it's agreed beforehand that the study will be performed by X or Y who has more experience or who has the study idea. And then all the other collaborators are called collaborators, and their name will be written, but as a separate appendix at the end of the paper. So the paper would say, author 1 to 3 on behalf of the RIFT group, for example, in the right iliac fossa study. And then at the end of the paper, there will be an appendix with all the collaborators and what is the role. Was it only data collection or data interpretation or drafting or, you know, idea or all these sort of things. So it all need to be agreed initially to avoid later on any conflicts.
Can I recommend?
Yes, sure, Dr. Sam.
Yeah. Actually, we have to differentiate between two things, between just collecting data, and this had nothing to do with national, international, or all these things. I think now data collections and the big data rule in the managing of everything in our life is the fashion. So actually, the rule of the red cap or something like that is to create this big data database. It's nothing about giving any information to do anything. If you want to do a multicentric study, as Shalabi said, this is something different. You have a very specified research questions, and you define a study design, and then you try to go a step further. It's not just data collections. You should have, or you need to have information. That's why you should interpret these data and try to make analysis of this data and convert the data from just a raw data into an information that can help you to take decisions and change your practice. Maybe, for example, the study about the spinal anesthesia in hernia in pediatrics, you can take the results of this study that is a multicentric studies. You increase the sample size by including a lot of centers, but actually you cannot do it international, because one of the most important features of a multicentric studies is the coherence of the setting in every center. You cannot compare a center that use MRI for diagnosis with center who doesn't have a plain X-ray in diagnosis. So doing a multicentric studies on an international level, it will not make any benefits for anyone. It will not do, because the group of patients will be very heterogeneous, that you cannot have a conclusion that be generalizable for all the settings that you had done the study with. And I need to know, I need all of our audience, my opinion is, publishing is not about publishing. Publishing is about changing the practice. If you want just to publish or first author, second author, fourth author, this makes no difference. Actually, you publish for changing practice. And what is very important is to try to interpret what are the people giving us, because not every published paper is worth of reading even. So this is very important. My message or my understanding is we should try to know how to understand what informations are given to us, to choose between the good and the bad, and to be able to change our practice, to improve our practice, to improve the outcome of our patients. So there is a lot of differences between multicentrics or a collaborative data set formations. This is very different two things. The first, the data set or the red cap way is you collect data from everywhere, and then you can take this data and make understanding and make use of it. A multicentric study is something else. It's something different, and it has certain criteria that should be fulfilled, so you can have a good study that can be benefited and can be generalizable. You can use in every setting and everywhere. Thank you.
Thank you, Dr. Osama. Dr. Mustafa Hamad have a similar experience with a case of lymphatic malformation, and he likes to share with us. So please, this will be the last for today. Please, Dr. Mustafa, you can share your case and your screen.
Assalamu alaikum. Good evening, everybody. Thank you for this elegant presentation and wonderful meeting, and thank you for giving me the opportunity to participate. I will share my screen. I have this similar case of the lymphatic malformation we faced in our institute. So this is a 3-year-old woman girl born in June 2017.
received 2 doses of intravenous injection. And also they combined this with oral prednisolone. He was referred to us at the age of 1.5 years. This is the photos for the child at the time he presented to us. You can notice it is according to the classification, it is stage 4. This is the images done for this child. Actually, it was showing a mixed lesion, a macro and microcystic lesion. And as I mentioned, he was already started on intralesional bleomycin injection. He received 2
Your voice is low, Muhammad, Mustafa.
Okay, is it okay now?
Better.
Yeah, he received already 2 doses of intralesional bleomycin injection. So here, after we repeated these images, the images reported that it is a mixed lesion, micro and macrocystic. This is the report, and this is the ultrasound also done for this child. The macrocysts, the maximum diameter of the cyst was about 17 millimeter. So in this situation, we consulted our intervention radiologist and we decided to proceed for intralesional bleomycin injection, and the child received 3 more doses of intralesional bleomycin injection. And all this procedure was under GA, and we faced a lot of obstacles and difficulties because we had to arrange PICU bed and post anesthesia ventilation for this child. And after the child reached the maximum dose of bleomycin injection, which is 5 milligram per kg, this is the photos for the child during the course of intralesional bleomycin. We did a multidisciplinary team discussion between us and the ENT surgeon, plastic surgeon, and maxillofacial surgeon, and also the interventionist. After this, we decided to start sirolimus. And the dose we started with, it was 0.8 milligram per meter square. And this was started in December 2019. And the child is still on sirolimus till now. These are the photos for the child. The upper one on the left was just before starting sirolimus, and these are like serial photos for the child during the course of sirolimus. And this is the photo today for the same child. As we can notice, the lesion in the cheek and the submandibular lesion much regressed, but still the tongue of the child is still a bit big, and according to the family, it is like there is on and off increase in the tongue size with frequent fungal infection in the mouth. So in this situation, I have few more questions if we have the time to discuss, like what we can do for the tongue. Is there any intervention for this one? And how long can we use sirolimus? And what is the limitations for using sirolimus? And if we are going to have like a neonatal case, is there any precautions for using sirolimus in these cases? And in such type of lesion, mixed lesion with macro and microcystic lesions, can we use combined treatment with intralesional bleomycin and sirolimus? Is it safe to use both drugs at the same time? And thank you very much for giving me the opportunity to participate. Thank you.
Thank you very much, Dr. Mustafa, for your case presentation, which is adding to our case. It's very similar in the treatment scenario. I think you had put many questions. I think, yes, sirolimus, like other drugs, it can work in some cases, and some cases it's not effective. We have tried sirolimus in different cases. We had very successful scenarios in cases with hemangioendotheliomas, cases with venous malformations, and cases with lymphatic malformations. Actually, the response, as any drugs, it's not similar in every case. And usually, of course, you can use combination of drugs, no problem, because they are not contraindication to use it with other modalities, even with the surgery. And I think this topic is still under clinical trials, and maybe we need many studies so that we can make a more clear picture for using this drug. Thank you very much, and I think
one word, Amr, yes, please. One word. Can I say one word?
Yes, of course.
Yes, thank you, Mustafa. We enjoyed you give us another proof that sirolimus can work. And as you said, there is a lot of questions, as Amr said, needs to be answered. Actually, we don't have the answer for all the questions that you presented now. What I want to say that in your case, it is microcystic. Most of the lesion is microcystic. So bleomycin should not be the first line of treatment. Although bleomycin can be of value if it is macrocystic in nature's not microcystic. So first, sirolimus is the first one. Number two is still there is a room for surgery in the tongue. If the tongue is not improving and it still is protruding and the patient is not able to close his mouth, there is a rule for glossectomy with all its types that can be of help to help these patients. As well as there is a rule for laser therapy for the lesions that is found on the surface of the tongue, and as well as in the on the surface of the mucosa of the aerodigestive tracts. You can use carbon dioxide laser or pulsed dye lasers to deal with these superficial lesions. That is very helpful, especially in the tongue area and the aerodigestive tract. So what I want to say, this tongue we have to re-evaluate it, see if the lesions is still there and not responding to the sirolimus for a reasonable time. We have to go and do surgery for this macroglossia in a form of glossectomy, partial glossectomy, of course, in a different ways. We can discuss this later on. But what I mean, surgery by partial glossectomy in these patients may be needed in the near futures if there is no too much response to the sirolimus. And another important thing that I forget to say, that sometimes the lymphatic lesion is not a pure lymphatic lesions. It's a mixed lymphovenous lesions. So we have to take care of this, and we have to quantify how much lymphatic, how much venous in the lesion of these patients. And that is the beauty of the MRI, especially with vascular anomaly protocol, with the contrast injection that Dr. Muhammad had explained how to read the MRI in these patients and differentiate between venous malformations or lymphatic malformation using MRI, T1, T2, and with or without contrast. Thank you very much.
Thank you.
Excuse me, I'd like to thank Dr. Muhammad Chalabi for attending. Welcome, ya Muhammad, Alf, welcome. And I'd like to thank again Mustafa Ahmed for presenting and sharing. I think this is the first time for somebody outside Egypt to share with us, and would like to encourage that. Muhammad Chalabi, please present something for us. Maybe in 2 weeks' time, you can present some UK experience. Muhammad Chalabi is a consultant pediatric surgeon in Bristol Children's Hospital, and he's one of Ain Shams. We have actually a great pride in having him over there, and all his colleagues, Kareem and the other Ayman. And I'd like to thank you all. I'd like to thank Amr Zaki. I'd like to thank Osama definitely for the effort that he did, because actually the presentations today are very short and to the point, and they're very illustrative and illuminative. Thank you very much, everyone, and inshallah we'll see you in 2 weeks' time.
Thank you, everyone. I enjoyed it so much. Inshallah, نشوفكم على خير.
Okay.
شكرا جزيلا.
شكرا جزيلا.
Thank you.